Good afternoon and welcome to the next in the series of the Royal College of Pathologists Guideline Implementation Webinar Programme. My name is Peter Johnston. I'm the Vice President of the College for Professionalism. I'm delighted this afternoon to host this webinar where we have a leading panel of experts who are going to present the data set on the implementation guideline for reporting liver resections, including gallbladder, liver biopsies for primary and metastatic carcinoma. The purpose of this webinar is to clarify what's new in the guidelines to help aid implementation and provide you with some tips as to how best to go about implementing these guidelines. I'm delighted to introduce the speakers for today, Professor Robert Goldin, Dr. Judy Wyatt, and Dr. Dina Tiniakos, who are going to talk about the guidelines. Before I introduce them, let me just remind you that this presentation will last about 15 minutes, during which each speaker will talk for about 5, and that'll be followed by a question and answer session for about 20 minutes maximum. We'll finish at 1:45. All participants will be muted, so if you want to ask a question, please do so using the Q&A button on the Zoom console. What we'll do is that I will pick up those questions and pass them on to the panel for answering. And so without further ado, I'd like to start off by inviting Dr. Judy Wyatt to introduce this session to you. Judy.
Thank you very much, Peter, for that introduction. And I shall press straight on with sharing my screen. So this webinar this afternoon is to deal with the update in the liver dataset documents, which I was joined in as co-authors with Stefan Hubscher, who's now retired, and Rob and Dina, who are going to co-present this session with me this afternoon. There we are. So this is just an overview of what I'm going to be saying. I'm going to provide a context and some introduction, what this is for, and then Dina will take over and deal with hepatocellular neoplasms, and then Rob will finish off with all things to do with the biliary tree. So the purpose of the data set, as with all the college data sets, is to define the data necessary for uniform recording and staging of liver cancer resections, the primary purpose, in sufficient detail that no matter where your resection has taken place, the stage of your cancer should be reported in the same way anywhere in the UK. There are about 23 liver cancer centres in the UK handling resection specimens, which is the main purpose of this document. But in addition to all of the primary liver cancers, we also include a section on metastatic colorectal adenocarcinoma, and also a substantial section on reporting needle biopsy specimens, and that's copied into the tissue pathways document. The users of this is primarily pathologists, and this will include BMS staff now who might be dissecting the resection specimens. And secondarily, because we're reporting in a uniform way, the clinicians and cancer registries should benefit, and of course also the patients whose specimens we're dealing with. My overview is really just to signpost you to what's new in the document and mention a few of the appendices that we've added at the end. Without any great detail. Now, you'll remember that the TNM8 was issued in 2017, and we were required to start using those criteria for reporting in January 2018. And the authors of datasets were encouraged to update their datasets so that we could give the details on how to apply these new criteria. We started working on that in 2017 and eventually submitted in 2020. And that delay actually turned out to be very useful because a lot of other relevant documents had been published in the meantime. And also we were able to harmonize with the about 6 other college dataset and pathway documents, which impinged on the way we deal with liver cancer specimens. After September 2020, there was another 2 years before the document was published. And during that time, a big team working behind the scenes in the college, which we're really grateful, were able to provide things like the SNOMED CT codes and the reporting for pro formas in list format. But it meant that the references needed then updating for the last 2 years that had happened. And eventually, after all that, the data set appears on the college on the college website, having been through a very useful consultation period. So what happened in the meantime? Well, here's TNM 8 matching AJCC 8, which comes out at the same time. The only difference being that neuroendocrine tumors primary in the liver are also included in this one. We've been using TNM 8 since January 2018. Later on in 2019, the WHO Blue Book comes out, and that has really useful information about how to actually diagnose the tumors as opposed to how to stage them, which is the province of these two. McSween was updated, and also I'd recommend this textbook to you if you haven't already got it. It's really useful details about very up-to-date overview of liver cancers. This slide will show you the changes that have been made, which occur in the text part of the data set. And you can see, with the exception of specimen handling and perhaps the core data items, especially in macroscopic, each of the microsections has been substantially updated in this, together with the needle core biopsies. You can see a lot of rewriting has happened there. So recommend some up-to-date information here. And the main purpose of this is to collect everything that might be useful to you in reporting these specimens all together in one place. The references went up a lot as well, and 98 of these 144 have been added since the previous version. The number of tables has gone up a lot, so overall the size of the dataset document over the 3 versions has increased a lot. But so has the changes to the way TNM classifications have worked. And this Appendix B just highlights in red the different alterations to TNM classification that we need to know about if we're going to use TNM8 correctly. I want to also signpost to you some of the appendices which are included in this data set. One of them is Appendix N, and this is the subtypes of hepatocellular carcinoma. This is on the horizon. These aren't core items yet, with the exception of fibrolamellar carcinoma, but it's signposting the way to the future, where the molecular changes in hepatocellular carcinomas are becoming associated with recognizable morphologies, but there's some way to go yet. Dina will say a little bit more about this in a minute. We also have some useful tables, I think, on immunohistochemistry, all gathered together in one place. What's useful in distinguishing well-differentiated hepatocellular lesions, carcinomas versus dysplastic nodules in cirrhotic livers, and also carcinomas versus hepatocellular adenomas in non-cirrhotic livers. So recommend those 2 tables to you. And also a detailed table about differential diagnosis in needle biopsies primarily. How do we know whether we're looking at primary carcinoma or metastatic carcinoma in the liver? Well, for tumors that morphologically, if they were primary, would be hepatocellular carcinoma, I have 2 detailed tables here, how to separate primary from metastatic. Whereas tumors which look more like an adenocarcinoma, so our quandary is whether this is a primary cholangiocarcinoma or whether this is metastatic, you're now referred to the data set for cancer of unknown primary, which has been published since the original or the previous data set. Just to mention, the bit that hasn't changed very much is the specimen handling, the same picture of the segments of the liver and the names of the different sorts of specimens that we get, to really emphasize the usefulness of knowing the preoperative imaging before you start slicing up a liver and discover what's actually on the inside of it. This hasn't changed. What has changed a lot is the microscopic sections, as I mentioned. We'll go over to Dina in a moment. Just before we do, metastatic colorectal cancer is a bit of an orphan here because it doesn't have its particular section in other dataset documents. But the number of resections, at least in Leeds, outnumbers primary cancer resections by 2 to 1. And we can tell the surgeons useful information about the likely outcome for the patients after they've had their resections. And the details of that, together with chemotherapy changes and so on, are included in the data set. So that's all I wanted to say. And now I'm going to hand over to Dina. Stop sharing my screen, and Dina will take on to tell you about hepatocellular neoplasms.
With the hepatocellular neoplasms, there have been some changes in the TNM8, as Judy outlined, and I will also discuss about the hepatocellular carcinoma subtypes, and I will also talk about the changes in hepatocellular adenoma. The TNM8 changes that started to be applied in January 2018 refer mainly to PT1, where in the TNM8 is subdivided in PT1A and PT1B based on the presence of vascular invasion if the size of the tumor is less than 2 centimeters. And also the PT2 has changed because now we have the size as important, more than 2 centimeters with vascular invasion. And this is because vascular invasion has prognostic information when it is related to tumors more than 2 centimeters. Also, PT3 has been now not divided as it was in 2010, and multiple tumors any more than 5 centimeters is a PT3. And the PT4 now is the stage where we have involvement of a major branch of portal or hepatic vein. Regarding the hepatocellular carcinoma subtypes, as already mentioned, this is not a core item yet, but it's going to be significant in the future when we have more information about the molecular changes that we can correlate with the morphology. So we recognize the steatohepatitic, clear cell, macrotrabecular, massive, serous, chromophobe, fibrolamellar, and the more rare variants of neutrophil-rich and lymphocyte-rich. All this may be related with prognostic information, predictive information, and morphomolecular correlation. We know, for example, that the macrotrabecular massive subtype, which I will discuss in a minute, may be related with a worse prognosis and also has 100% vascular invasion. The steatohepatitic hepatocellular carcinoma is recognized because more than 50% of the tumor shows features that resemble steatohepatitis with balloon hepatocytes and Mallory-Denk bodies and inflammation and intratumoral fibrosis. There is a table, the Appendix N, where we describe the different features for its subtype. Clear cell hepatocellular carcinoma has better prognosis to hepatocellular carcinoma NOS, and we need to have a clear cell morphology in more than 80% of the tumor. The macrotrabecular massive, where the trabeculae are increased in thickness for more than 10 cells. The serous hepatocellular carcinoma, where there is a dense hyalinized fibrous tissue, and these tumors, when they are large, they behave worse compared to NOS HCC. The rare variant of chromophobe hepatocellular carcinoma with pseudocysts and sudden anaplasia also is related with certain molecular changes. And the well-known to us fibrolamellar hepatocellular carcinoma still recognized as a separate subtype with the lamellar fibrosis and the distinctive eosinophilic cells. This also can be confirmed with the use of CD68 and keratin-7 immunostains. Regarding the tumors that arise in non-cirrhotic liver, we refer in the new version of the dataset a lot of the differential diagnosis between FNH and hepatocellular adenoma and the different subtypes of adenoma that we may be able to recognize based on morphology. These are mentioned in the text, and also in the Appendix P, we may see the main types, the inflammatory, the HNF1A inactivated, and the beta-catenin mutated. The beta-catenin mutated is important because it is related with malignant transformation. And also there are other subtypes like the sonic hedgehog, which is related with increased risk of hemorrhage and bleeding. The minimum immunohistochemistry that the dataset discusses is the presence of glutamine synthetase that we may have in the lab, beta-catenin and amyloid A or CRP. And there may be cases indeed where it is difficult to differentiate hepatocellular adenoma from well-differentiated hepatocellular carcinoma. And in these cases, we may use terms like hepatocellular neoplasm of uncertain malignant potential or atypical hepatocellular neoplasm. But we are going to discuss further with your questions, and thank you very much for your attention till now. And Rob can continue with the biliary tract related tumors.
Thank you very much, Dina.
Thanks very much. So similar sort of structure to Dina's presentation, into TNM changes, a little bit about changes in histology, cholangio and combined tumors, and gallbladder cancer. Of course, the biliary tree has extrahepatic, intrahepatic components, as everyone knows very well, and there are differences in different sites, how we have to approach them. And I'll just say a little bit about molecular studies at the end. So here are the TNM changes for intrahepatic cholangiocarcinomas, comparing 7 with 8. The normal kinds of things: 1 has been now split into 2 categories. 2, which was 2 categories, is now unified to 1 category. I mean, these are minor changes, but you continue to have to study and look them up, or at least I do each time I do it. And there are changes in T3 and T4. I'll say a little bit more about this. I mean, I guess we can anticipate in the lifetime of this document that we're launching today that there will be changes in the staging system. I want to say a little bit more about gallbladder. First of all, because gallbladder tumors are likely to be the ones that are seen most frequently by non-specialist hepatobiliary pathologists. Of course, the college recommends, and I think it's correct, that even in the UK, all gallbladders should be submitted for histological examination. So some of the changes are mild, but the ones I want to really highlight are here, 2A and 2B. These are tumors which invade the connective tissue, don't go through the muscle, but they're divided now into those which involve the serosal, the visceral peritoneum, and those which invade into the liver. Even though the stage is the same, the site of invasion is now really important. And I'm not showing you the data on which this is based, but if you look at the survival figures, they're very significant. And I noticed that in cases referred to us for management when I review the pathology, this is something which people really haven't totally bought into yet. I think it's important because it's prognostically significant and affects patient management. Regard number of lymph nodes, we're used in colorectal pathology, very stringent guidelines to how many lymph nodes we should be looking. These are the sort of range of lymph nodes that people are looking at. I'd be interested to know what my colleagues and other people in the audience think. I think these are quite a lot more sometimes than we often are given. And that the other point to highlight in TNMAs is there's in perihyaline gallbladder cancers, there's a PN2 category. There's not just a single node category. But as ever, I think it's a matter of going back to the guidelines each time you have a case and looking it up. This is a slightly heretical slide to put in. Comparing TNM7 to TNM8, there's been quite a few papers published recently, and if you look at the concordance for overall survival between 7 and 8, you'll see it is very, very, very slightly better. Doesn't mean we don't have to use it. We have to use the current system because that's the language we share with other pathologists. But I think we can anticipate, being optimistic, that the next edition will provide a greater predictive index. I'll just say a little bit about types of intrahepatic cholangiocarcinomas. This is now quite well recognized, but again, not always used. That there are 2 types: the small duct and the large duct. I mean, the names are pretty self-explanatory. The large ducts have columnar epithelium, prominent mucus production, and the small ducts more anastomosing cords of cells. This is not just pathologists collecting stamps. If we look, for example, next slide, looking at the large duct type, these tend to arise in the segmental bile ducts. They often have infiltrating periductal growth pattern and have different precursor cells and often have worse prognostic features and indeed do overall worse. So this is again an important clinical distinction, and on the whole it's quite straightforward. And a thing which rejoices me is that it can be done on an H&E. Not to say there are not important molecular and other differences. We're going to talk about combined treatments now. So this is really an overlap between Dataset and my bit. So liver CCs we've heard about. We say that they're normally cytokeratin-19 negative, but that of course is not true in a significant number of cases in which CK19 in classic HCCs may carry prognostic significance. I'll come back to that. Cholangiocarcinomas, of course, almost always CK19, or more correctly, as we have here, K19 positive. But there are clearly tumors which share features of both. And here's a very clear-cut example. No one looking at the bit here would think that was an HCC. No one looking at the bit on the other side would think this wasn't cholangiocarcinoma. And yet they're clearly it's part of a single tumor, and that's reflected in the immunohistochemistry. Now, these are, here is a tumor, in fact, show all kinds of cancer together. Here is the large duct, columnar cells of mucin. Here's the small duct, anastomosis cords, and with HCC in the middle. They can all go together. Now, this is, something that we've known has existed for a very long time. There's been a focus for increased interest in recent years. I guess the most important take-home message is that this diagnosis is made on H&E. It's got to look like an HCC, it's got to look like a cholangio, and then you can make the diagnosis. Immuno is supportive at best because we already said HCCs can be CK19 positive, so that doesn't make it a mixed tumor. I think the other practical points, if you have a tumor, I think I personally now tend to take a few extra blocks because I'm into seeing even tumors which are predominantly one may have components of the other. So this is important to be aware of, but not can be underdiagnosed, but can very, very easily be overdiagnosed. So reinforce is on the H&E. And another type is the cholangiocellular carcinoma. This was in one stage included in the sort of combined tumor category, but it's now been taken up very obviously on molecular grounds, a kind of cholangiocarcinoma. And this just looks like anastomosing cords of bile ducts, often very well differentiated. I had one on my desk this morning. They can be CD56 positive. It doesn't make them neuroendocrine tumors. That's what things that you can see in proliferating bile ducts. So again, something to be aware of and to make sure you put it in the right category. There are simply undifferentiated tumors which are stem cell cancers, they're not, which may have immunohistochemical and molecular features of both HCC and cholangiomas. Coming on to gallbladders dysplasia now, it's quite straightforward that we divided into high grade and low grade. But one of the most common questions I get asked in my own department and by other people is, if I find low-grade dysplasia, how many more blocks do I need to take? And if it's high-grade dysplasia, what do I need to do? Now, the point is that for low-grade dysplasia, it's quite a common finding. I mean, it can easily be overdiagnosed, and I don't know any immunohistochemical technique which really helps in the diagnosis. It's an H&E thing again. I'm very keen on H&E things. If you find it, then you should take extra blocks, and the guidelines here are 1 block per centimeter. If you find high-grade bilin, then you should block the whole gallbladder. Why is this? Well, the answer is that high-grade dysplasia is almost always a very widespread phenomenon. So if you've got low-grade bilin and you're looking for high-grade dysplasia, then you don't need that many more blocks to confirm the diagnosis. Another kind of high-grade dysplasia, what you're really doing then, of course, is trying to exclude invasive carcinoma, and that will completely change the patient prognosis and management. So that's why it depends on what you see, how many extra blocks you have to take. Intestinal metaplasia, you don't need extra blocks. Certainly for pseudopyloric metaplasia, you don't need extra blocks. This is highlighted in our guidelines. There are some gallbladders you need to take extra blocks from. I think this is from a case of hyalinizing cholecystitis. We get this sort of dense monomorphic fibrotic replacement of the gallbladder wall, sometimes a calcification, part of the Boston gallbladder spectrum. This is an important thing to recognize. Again, simply being aware of it will mean you'll make the diagnosis, because these patients have a higher incidence of dysplasia and you need to take extra blocks. So would be the case, of course, if you had a gallbladder from a patient with primary sclerosing cholangitis. polyps. Okay, this is one of those kind of topics which is always kind of a bit of a challenge. So the nomenclature has changed here. Really, there's been application of the nomenclature from the pancreas to the gallbladder, just saying a few very simple things. We don't normally use the term adenoma now, except for the pyloric adenomas, which are pretty common. And intracholecystic ICPN is now the recommended nomenclature for tumors more than 1 centimeter. There's a whole host of terms listed there, which, as the blue book makes very clear, you should rather avoid using. Just as a practical point, these are very friable tumors sometimes, and you've got to be very careful when you open the gallbladder not to wash them away. And just some pictures show the papillary structure and the displays here. And of course, you need to examine it very carefully to exclude underlying carcinoma. Finally, coming on to molecular tests, FGFR2 is the one that we get asked for most, because the problem is this: cholangiocarcinoma carries a bad prognosis, and therefore the clinicians, oncologists, are always looking for to apply new treatments. And therefore we had to be particularly miserly, I think, on asking for extra stains and things on cholangiocarcinomas when you have a liver biopsy, because a high percentage of them will require molecular studies. The next slide, which is not from the guideline, shows, this is from PSC-related tumors, a list of all the mutations that have been described and the druggable mutations in them. Different studies have shown different things, but to be fair, although it says low prevalence, FGFR2 and IDH1/2 mutations are quite frequently we're asked for molecular studies. We could have a discussion about whether any of these should be done routinely, but I think this is an important point. Cholangiocarcinoma, the prognosis will get better, but it will get better if we as pathologists help by making sure the material is available. And that is happily to the introductory slide. So I have finished.
Many thanks, all of you, for the really interesting and very helpful presentations. Thank you for that. Just a call to the audience. We're a bit short on questions. None of you who's put in a question yet. We've got some that were sent in before. I've got a couple just that come to mind as we go. So while we're asking a couple of questions that we've got already, would you please submit some questions so that we can address your personal issues as regards the diagnosis of these lesions. Thank you. I'd like to start off. This is a daft laddie question for Dina, really, is that if you look at the table you presented of special types or subtypes of hepatocellular carcinoma, my quick arithmetic was about 40%. Does that mean that the rest of them are not otherwise specified types of hepatocellular carcinoma?
Yes, thank you, Peter. Yes, the majority of hepatocellular carcinomas are non-otherwise classified. So up to now, these are the subtypes that we recognize. And I don't think this may change more in the future. I think maybe we may have first to correlate better with molecular biology and make sure that the subtype that we address indeed has a mutation or underlying molecular target that could be druggable, and this will show more in the future.
Thank you very much for that.
Thank you.
Still no questions in. So there are a couple of practical questions that we have. One is around blocking, and the other one is around investigation of these tumors. So the blocking one, first of all, if we get needle core biopsies, we frequently have to put those biopsies to an awful lot of work, so that we've got immunocytochemistry. But if, for example, it's not a primary hepatocellular lesion, but a metastatic one, say lung, for example, or indeed GI, or if it's a lymphoma, we want to do a lot of other things. Do you recommend putting all the material in one block? Or if we've got more than one block, do you recommend using different blocks for cores so that we can maximize the amount of investigation we can do from these often rather fragmented, miserable little specimens? Don't know who wants to pick that one up.
Well, I can tell you what
Judy.
we're doing I can tell you what we're doing in Leeds. I'm aware that other tissue sites tend to recommend splitting up the cores into separate blocks. We don't do that at the moment for targeted liver biopsies. We put it in one block. We do a couple of superficial levels of H&E, saving spares in between, and aiming to have plenty of tissue left in the core. That I think the pros and cons really. It means that we can do all of the stains on one block rather than having to choose the best one, especially since tumours are quite often a bit mixed. But yeah, so we haven't gone down the route here locally of splitting into different blocks. I don't know what the other two do.
We don't split it either. If I may just ask a question, often we get, not often, but we get liver biopsy, breast cancer, liver met for markers, lung cancer, known liver biopsy. Our practice at Imperials, we hand those over to the breast and to the lung pathologist straight away because we think those are not really liver problems. I just wonder whether other people do the same.
Well, it's an interesting question because it's a bit of ear chewing that we get sometimes from various people in different specialties who've got different views on it.
Yeah.
I mean, I just think the breast people are the best people to assess breast receptor expression.
Certainly my lung colleagues would say the same about lung tumours, but and I mean the difficulty is that you know, for lymphomas, that if it poorly differentiated lesion, we do an awful lot of immunocytochemistry for things that it turns out not to be, which is useful to tell us what it's not, but not useful to tell us what it is. So it's that, you know, it's just how best to balance, and it is a balance, I believe, as to how we best do that. I guess it's a judgment call on what your local practice is, but as long as we're aware of the risk, and my approach personally would be to involve people at an early stage and say, look, I'm looking at this and I'm thinking, what do you think? And that way we best use the material we have. But I don't know, Dina, have you got a comment? Judy? Sorry, Judy, you seem to go first.
Okay, well,
Judy may go first.
I'll go very quickly. Just say, I mean, these targeted biopsies do come to the liver team first in Leeds, and we have a quick look. And if it looks as if it's going to be breast, then we have a very low threshold for handing on to breast people. But quite often the tumour isn't the one that the clinicians thought it was likely to be. And I think the really important thing is the tissue economics. You don't want to use up all of your sections in like Peter was saying, deciding what it isn't. We want to have early on, just especially for something which these days may be primary cholangiocarcinoma rather than metastatic adenocarcinoma, because that's where we really do need to make sure we've got tissue left to do the molecular work on now. So it'll depend on people's local practice, I'm sure, but the important thing is the tissue economics one, I think, and not to waste tissue with a big panel of stains which turn out to be irrelevant to the actual clinical question. Don't know what Dina does.
Yes, I agree, Judy. This is the important thing, is to try to save the tissue. And this is a common practice for all of us. I was just thinking, even if we need to spare the tissue, even if we have the core in one block, we can later split it up if we see that it may be needed, because we can always, you know, melt the paraffin and create two blocks if we see that it may be needed for a very difficult tumor that may need extra stains.
Good,
And even if we have, unstained slides, we can always scrape the tissue for molecular analysis. So this also helps.
Thanks. Your comments about special stain segues nicely into a question that we had submitted earlier, which is around the use of, you know, what we would call traditional liver histochemical stains, PAS, trichromes, reticulins, etc. And the questions are, do we recommend ordering these stains that are done on medical liver biopsies on, first of all, metastatic, and secondly, primary liver tumours? I don't know who would like to answer that.
Well, I can answer that because we discussed this with, yesterday we had a practice session, And this is something that it will be interesting for all of us. So if we are dealing with a primary liver carcinoma, then we think it is best to do the whole liver panel in the background liver. But with the metastatic colorectal carcinoma, we can check the H&E, and if it is needed, then we may ask for some extra stains. So that was the consensus.
Yep, thank you very much. Just from the questions that have come in, thank you very much. There was something that you said earlier, Dina, also about atypical neoplasms, and that there's a sort of related question in here, which is about here we are. Is it possible to differentiate focal nodular hyperplasia from hepatic adenoma on frozen section? So, I mean, those criteria are difficult criteria at the best of times. And it's how do we deal with that in the context of what you mentioned earlier, which are atypical neoplasms, and how far can we go?
Well, I think in a frozen section, first of all, it will be quite rare to get an FNH because usually the imaging helps differentiate. So they may know in advance that it is an FNH, but I think it will be even difficult for a well-differentiated HCC to be differentiated from a hepatocellular adenoma on a frozen section. So if for an FNH, if we see the scar and the abnormal vessels, I think we may be able to suspect, but it will be better if we don't see any dysplastic changes or any other material, then it will be better if we wait for the fixed specimen.
Thank you. That's helpful. And just in passing, there's a comment about what we do with metastases from another site. And again, this contributor is saying that, like we've discussed, they tend to show the other specialist early on in the process. Question about biomedical scientists and cut-up. What do we think about having biomedical scientists cutting liver for metastatic resections? Are you content with using biomedical scientists in cut-up?
We certainly are for metastases, and some of our better, more experienced ones do primary tumors as well.
Yeah, it's all about training and appropriate.
It's all about,
yeah.
It's like anybody. Yeah.
Yes. You raised a question earlier, Rob, about lymph nodes, and there's a contributor says, with many liver resections, we get very few lymph nodes. If there is one, for example, it might be a cystic duct lymph node, and how do we document this when we've only got one, or what was the system? And you mentioned earlier about how many lymph nodes do people tend to get, and how does that play into the staging process?
Yeah, I mean, I think that, I said it as I spoke, that I think we get relatively few nodes compared to some guidelines suggestions, and I think that the consensus is you have to stage on what you've got. I think often we get very big lymph nodes, often very big reactive lymph nodes, and I think then it's important to make. It's not only one node, you can't pretend it's more, but I think you need to look at them carefully to make sure there's no small deposits hidden inside them. But I think you just got to deal with what you've got and call it what you have. It's not so colorectal, of course, is sort of set the standards for this kind of thing, but I don't think they exist for hepatobiliary, but I'm very interested in what my colleagues think.
I'd agree that this problem of large lymph nodes with micrometastases in is a really common pitfall, isn't it, from metastatic cholangiocarcinoma, where the size of the node bears no relation to its likelihood of harboring a metastasis. And yeah, I think one of the things which I think Rob might have put in as a reference is if we find metastatic cancer cells, but only by immunohistochemistry and not on an H&E, then apparently that doesn't have a bearing on the prognosis. So we need to be able to recognize metastases, even micro ones, on an H&E section to call that a positive situation.
Thank you. There's also a question which is about microscopic invasion of bile ducts. capsule and adherent tissue. And the note is that it's been removed from the reporting pro forma. And the question is, why has this been taken away?
Yeah, well, I suppose I should deal with that one because I talked about that bit of the section. The bile duct bit, that's been taken away because that hasn't been shown to have any or any consistent effect on the prognosis afterwards. There are reports saying that it's a good feature and reports saying that it's a bad feature, but there's no consensus on which it is. So that was why that one was taken out. In terms of the adherent tissue, I had to say I hadn't realized that it had been taken out, and I think it's something which we would comment on in writing the report. And if when I go back and have a look it's not there, then that's probably an accident, and I think it is usefully recorded, not least because clinicians are deterred from biopsying colorectal cancer because of the risk of upstaging disease. And invasion into the chest wall, adhesion and invasion into the chest wall is really common after biopsying and metastatic colorectal cancer, which is the reason for really not doing it. And I think it's useful to document whether that sort of invasion has happened in a resection specimen. It's not very common to find invasion outside, through the capsule and beyond, I think.
Thank you. We're beginning to run short of time, so just quickly before we end, you mentioned, Rob, that there was a lot of advance in terms of the way in which we approach the molecular diagnosis of these tumours. Going forward, I guess the answer to this simply is yes, but in what way do we see molecular advances in molecular pathology and the tie with targeted treatment going? What's the direction of travel that you perceive over the next 5 years?
Well, I think that's another site, and I think it's true, Dina, I think we're pretty confirmed, for hepatocellular carcinomas, even tumours which are now absolutely certain on radiology to be HCCs, which people would not have biopsied, are now, in the latest guidelines, biopsied because the necessity of doing molecular and immunohistochemical studies. So I think it's an increasing indication for the biopsy itself. I mean, in the old days of cholangio, all we were saying was adenocarcinoma, and we often with cholangio can't be certain it is a primary without the imaging to exclude the other possible sites. So again, the increasing reason for doing these biopsies and making sure they're adequate is molecular testing. So, I think really we have to work very closely with our oncology colleagues to know what they need, what they want. And this is often very specific to particular trials that are available. So I think it's an ongoing dialogue we have to have.
Well, thank you all very much. I think just before we go, I think there seems to be consensus from some of the comments that biomedical scientists and advanced practitioners are being more widely used to look after the dissection of a lot of these sorts of specimens, as is the case in many areas of our practice. So I think because of the time, we should probably draw this to a close now. And I would just like to inform people that the webinar, together with the question and answer session, will be available to members and fellows on the college website in due course once it's been edited for that purpose. And so if you weren't able to join us today, or if you've got colleagues who weren't able to join us today, they can go back and look at it again. And so just to conclude, I would like to thank very much all of you who are involved in the production of the guidelines, Judy, Dina, Rob, and Stefan Hubscher, who was not able to attend, for contributing to this upgrade of the guidelines, and to thank you all for the presentation. I would also like to thank the professional guidelines team, formerly known as Clinical Effectiveness in the Royal College of Pathologists, particularly Maria Marrero-Feo, Cynthia Mitri and Gamze Zen, who have put together this a presentation and run the show for us today going forward. So thank you all very much. And I hope that you've enjoyed this, and I look forward to welcoming you again to the next in the series of college guidelines webinars. Thank you very much and have a good afternoon.
Thank you.
Thank you.